And welcome to the Philosophy of Psychiatry webinar. Before introducing our speaker of today, just to let you know that talk will be recorded. So if you don't want to appear in the recorded version, just shut down your camera. So this is the last session of this fall webinar, and we are very pleased to welcome Miriam Solomon, who is a professor of philosophy in the Department of Philosophy at Temple University. Miriam Solomon's work lies at the intersection of philosophy of science, philosophy of medicine, philosophy of psychiatry, history of science, epistemology, gender and science, and biomedical ethics. She is the author of Social Empiricism, published in 2001 at MIT Press, and Making Medical Knowledge, published in 2015 at Oxford University Press. She's also the co-editor with Jeremy Simon and Harold Kincaid of the Routledge Companion to Philosophy of Medicine. She has also produced over the years many significant contributions to social epistemology, philosophy of medicine, and philosophy of psychiatry. Her more recent papers include Trust, the Need for Public Understanding of How Science Works, published in the Hastings Center Report, and The Problem of Aggregating Validator for Psychiatric Disorders, co-authored with Kenneth Kendler and published in the Journal of Nervous and Mental Disease. So I'm now very pleased to give the floor to Professor Miriam Solomon for her talk entitled Towards an Ameliorative Account of Psychiatric Disorders.
Thank you so much, Anne-Marie and Sarah. And as I share my screen, I'd like to thank you all very much for arranging these seminars. I've enjoyed them very much in the past year. It's been one of the good things about the pandemic, and I hope it continues past the pandemic. So here we go with my screen. Okay. So I'm beginning a project, which is why it's called Towards an Ameliorative Account of Psychiatric Disorder. This is the second time I've shared it. The last time was last week. So it is pretty new and pretty rough, and I'm eager for feedback. I wanted to mention two inspirations from what I'm doing. One is the philosopher J.L. Austin, who has influenced my work since graduate school. His ear for words in context and for misuse of words is a sensitivity that I attempt to go for, although I don't have anything like his skill. And I'm also inspired by Sally Haslanger's work on ameliorative concepts. So while Austin was somewhat conservative and thought our concepts were just fine enough from everyday life, Haslanger would like to improve them. Here's an overview of what I'm going to do. I'm going to first of all talk a little bit about disease and disorder in general, with some historical and philosophical overview. And then I'm going to say a few things about my approach. And then I'm going to go to a case about words about migraine, which is a physical disease, not a psychiatric disease. But it was a project I worked on about 10 years ago, and it came up with a result that was surprising to me and has stayed with me and has influenced me as I've started work in psychiatry and the concept of psychiatric disorder. I will set out what the recommendation is and the ways in which it differs from other accounts of psychiatric disorder, and then draw some conclusions. I'm certainly not giving a full account of psychiatric disorder. I'm making steps towards an approach towards such an account. This is just a word cloud, and I have no idea what the database is, but I put it up there just as a visual aid to the reflection that the concept of disease and related concepts have been with us for a very long time and have been understood in very different ways, not just because there are many diseases, but because there have been many theories about disease, ranging from punishment of gods to natural processes to invasion by, and so on. There've been a lot of metaphors used, diseases sometimes described as with war metaphors. So I just want to put it out there that the disease type words are come with a very rich history, and lots of associations, and not clear coherent concepts in that sense. One way to show this is specifically in the historical work of Charles Rosenberg, the historian of medicine. And this sentence from a paper he wrote about 30 years ago always comes back to me. He said, disease is an elusive entity. It's at once a biological event, and even it's an event, or is it a state, or is it, we can go on about that. A generation-specific repertoire of verbal constructs reflecting medicine's intellectual and institutional history. There's a lot packed in that. And what he's telling is how the concept changes over time, yet reflects the history. So the history is going to be represented differently in different times, though it will be still there. He says it's an aspect of potential legitimation for public policy, a potentially defining element of social role. So he's talking about public policy to reduce the, quote, disease burden. He's talking about having a disease as legitimating what sociologists have called, quote, a sick role, a sanction for cultural norms around sickness, and we have a lot of those, and a structuring element in doctor-patient interactions, namely when you see a doctor, the quote disease or ailment that you're going to see the doctor about is what structures the interaction. And it doesn't have to be that way. We could have maybe health structure the interaction, but we don't. I mean, we only have health structure the interaction insofar as we think of it as the absence of disease. So he's telling us the many things that the word disease and the concept disease and its associated terms do for us. Philosophers have worked for a long time on accounts of both disease and psychiatric disorder. And they share a history of being very difficult to analyze philosophically, a history of proposals and counterexamples. Biological psychiatrists would take psychiatric disorders to be a subset of physical diseases, which raises the question, why aren't they called psychiatric diseases? The answer to that is it probably has to do with the stigma attached to the word disease, which we will get to. There are paradigm cases that are definitely within the scope of physical disease or psychiatric disorder, heart disease, cancer, PKU. Those are within the scope of disease. Some profound depression, schizophrenia, and bipolar disorder are typically put within the psychiatric disorders, and nobody's proposing removing them from the category. But there are lots of difficult cases. And the difficult cases on the physical disease side include things like short stature, plastic surgery for reasons of social conformity, such as treatment for hyperspadias and cleft palate. On the psychiatric side, personality disorders, paraphilias, and grief, things that are disputed as to whether or not they belong in the disorder category. I think they're difficult rather than indeterminate. We're not happy to say, well, you know, just some of them are indeterminate, they're neither one nor the other, because provision of care currently depends on having a disease or disorder status. That's the plus side of having disease or disorder status. And the negative side is that sometimes having disease or disorder status is seen as inappropriate and sometimes stigmatizing. A lot hinges on it, and there's pressure to resolve these difficult cases. The usual philosophic strategy is to look at the paradigm cases, use them to come up with a general definition, and then use it to apply to the difficult cases to help resolve them. Here I'm just summarizing up a very large literature and my take on it, which you may not agree with, but I think we haven't managed to find a concept that helps resolve all the difficult cases. And I'm just referring some pieces that have this conclusion. I particularly like the paper by Jennifer Worrell and John Worrell, a physician and philosopher pair who argue quite forcibly that the concept of disease is not something that a doctor needs to have, and that resolving the difficult cases does not depend on having a definition of the concept of disease. In psychiatry, there is a key historical case in the evolution of our understanding of psychiatric disorder, and that's the case of homosexuality. The early 20th century and the early versions of the DSM labeled homosexuality a psychiatric disorder. This was resisted and and the resistance had a good deal of support. And the story of how it was, quote, voted out is a very interesting story. But the core argument was that homosexuality should not be considered a disorder because it's not harmful, by which it was meant it does not cause distress in the person who has it. And the only distress caused by homosexuality is the distress caused by societal disapproval of it, or some of society's disapproval. And that's understandable and appropriate, but not something that reflects on homosexuality, reflects on society. So the idea is that diseases and disorders are called that way because they are harmful, and not because they're deviant or different or abnormal or unnatural or any of those other words, became central to our understanding of psychiatric disorder. And Rachel Cooper has talked a lot about this. In this way of understanding psychiatric disorder, the provision of care and the allowance for accommodations is justified on the grounds that it reduces harm. It's a simple ethical justification. If somebody is experiencing harm, then they're deserving of care and they're deserving of accommodation. I mentioned parenthetically, but won't follow up, that Rachel Cooper discerns a new use of psychiatric disorder to cover states that are not in themselves harmful, like mild Tourette's. And that's because mild Tourette's is classified as a disorder because it has the same neurology as severe Tourette's, which is harmful. And what you see going on there is it's not just harmfulness that's playing a role, but also the underlying scientific account of the disease is playing a role. And all that goes to say is the concept of psychiatric disorder is very complicated and very equivocal. And although harmfulness has played a leading and central role in late 20th and early 21st century psychiatry, it's not the only thing going on. So what's my approach when I look at psychiatric disorder? I'm very keen on looking at it genealogically, historically, looking at change over time to the present, understanding how the term is used, even when it's not obvious or not acknowledged. So I'm interested in nuance. I'm not going to run away from incoherences in use of the term. I find the philosophical method of limited value for this kind of concept, because I think you cannot figure out just by reflecting on your own conscious ideas what the meaning of the term is. Psychiatric disorder is the currently preferred term. It's preferred to disease, abnormality, crazy, insane, and so forth, in part because it's thought to be less stigmatizing, that it's a gentle word. Disorder is a gentle word. However, it's not free of stigma. And I say this partly because I'm going to discuss a case where it's not free of stigma, but also because in general, it's a feature of words for stigmatized conditions tend to become offensive over time. And that's why we have to move from one term to another over time. And that we've seen that in the disability, in concepts of disability, where handicapped is not a word we use now. Handicapped has become stigmatized, and we've moved to other words. So I was looking for a word for this phenomenon, and the only thing I could come up with is pejoration, as in words getting more pejorative over time. But it would be good to have a term specifically for how words that are designed to be stigma-free then gather stigma as they are used. I want normative change recommendations for change in the meaning of psychiatric disorder to make things better, scientifically or ethically. That's the influence of Sally Haslanger. However, if psychiatric disorder can't be improved, it should be replaced. I don't think we have to keep it. I'm open to finding out that it can't be improved in society as it is currently. Some provisional constraints on the concept of disease and disorder, especially in the USA. Disease and disorder status matters because it's tied to the provision of care, And at the same time, it's sometimes perceived as stigmatizing and thus resisted. So that needs to be borne in mind. We need to avoid denial of coverage for medically necessary treatment or loss of important care resources, such as health and education, that are tied to diagnosis. At the same time, we don't want inappropriate treatment, interference with conditions that do not need it, such as homosexuality, such as paraphilias or personality disorders. We would prefer not to cover treatment for inappropriate or low priority conditions given our resources. And there's one other thing that we want to avoid in a concept of disease and disorder. It's a phenomenon that Hilda Lindemann calls hostage taking. And what it is a way of avoiding the stigma of your preferred category by stigmatizing something else in contrast to it. And the first place I encountered this was in the category of Asperger disease, which was thought to be an important subset of autistic spectrum disorder. And when it was created in the early 90s, and it was part of DSM-4, it was presented as a diagnosis that wasn't quite as grim as classic autism, that it was more like non-neural typicality and eccentricity. People were relieved to get an Asperger's diagnosis rather than an autism spectrum disorder diagnosis. And whatever the scientific merits of that, which I think are few, the effect was one of putting down those with classic autism in favor of Asperger's. So that was an example of hostage taking. Hilda Lindemann talks about homophobic statements in rap music. That would be one stigmatized group, Blacks, putting down another stigmatized group, homosexuals, in order to make themselves feel better. So we do want to avoid that. We want to avoid saying that something is not a disease because we want it. We stigmatize disease. So we need to be careful about that. Okay, so now I'm going back to physical disease and to the case of migraine. And migraine is a phenomenon that's characterized by some combination of aura, head pain, nausea, vomiting, stomach pain, photophobia, phonophobia, and so on. It can affect people for part of their lives, all of their lives. It tends to be relapsing and remitting, and it can change in character over life. It's very poorly understood. For a while, it was thought to be a vascular disease because what is thought to be painful is the expansion of blood vessels. But more recently, it was thought of as a neural disease, a more central neural disease, and a condition like, I've seen the phrase cortical spreading activity or something like that. Anyway, a very vague neural theory. It's an example of what I call a Scotch condition, and I'm grateful for this term to Kareem Khalifa. I was telling him that what I'm looking for is a term for those biologic conditions that show significant change over time. That's the Scott part, complexity and heterogeneity. And there are a bunch of conditions like that, and migraine is most definitely one of them. So I was asked to participate in a consensus study of what to call migraine. Is it an illness? Is it a disease, a syndrome, a condition, a disorder, or a susceptibility? And along with that, what to call somebody who has migraine. Is it a person with migraine? Is it a migraineur? And so on. That was what we were charged with. I'm having a little trouble advancing the screen for some reason. Okay. The study resulted in a publication called Naming Migraine and Those Who Have It, which came out about 8 years ago. And participating in it were about 15 physicians, academics, advocates, and patients. I participated in this both as an academic and a migraineur, which is the word for somebody who has migraine, which some migraineurs like and some don't. Anyway, I had been reading about what migraine is, and I was awfully excited at the idea of finding out more about it. So I did some work on the neuroscience, and then I recalled Oliver Sacks's early book, Migraine, which is a phenomenologically rich account of migraine and migraine phenomena. And I thought syndrome and susceptibility were attractive concepts. And, you know, syndromic concepts are ones in which we describe a group of symptoms that are otherwise unrelated, except they seem to occur together in a particular condition. And susceptibility, because from what was said about the neural underpinnings of migraine, I thought it was possible that having a migraine attack is something we're all capable of having, but some of us are more triggered more easily than others. So that's where my head was, and I thought it was a biological question, although I was open to finding out that we need to consider using a non-stigmatized term for this invisible and sometimes stigmatized condition. So the results was that the group started with substantial variation over preferred terms. And discussion was, for the most part, not about our scientific knowledge of the disease, about what migraine really is. Instead, the discussion focused on issues such as the importance of having migraine taken seriously by the healthcare profession, the importance of research funders funding research on migraine, the importance of the workplace taking it seriously, and the importance of choosing a non-stigmatizing term. And this led to the group's rejection of the term disorder after one participant expressed concern that it, quote, sounded psychiatric. Just one person said that did it. Migraine could not be a disorder. I say alas, because why would it be so bad to be like a psychiatric disorder? So anyway, it also led to the rejection of terms like syndrome and susceptibility on the grounds that they would minimize acknowledgement of the disability caused by migraine. Syndrome and susceptibility sounded to people like they weren't being taken seriously enough, that migraine wasn't being taken seriously enough, and they thought it was important to use a word that signified, hey, this is real, this is serious. And not surprisingly, then, it led to the favoring of the term disease on the grounds that this would give migraine needed recognition, and it would avoid inferences that migraine is, quote, in the head, which of course it is, but you know what I mean. The word condition was the second most preferred term, but disease won out. What question is what to learn from this case? Migraine has something in common with psychiatric disorders in that it's somewhat invisible. The symptoms are mostly subjective, and its etiology is poorly understood. So likewise, with psychiatric disorders, we are frequently describing them in syndromic form. Nevertheless, as with psychiatric disorders, it can be profoundly disabling. So there is that similarity. Terms like disease, condition, syndrome, susceptibility, and illness, and so on, have subtle scientific differences that are sometimes worth emphasizing. For example, the idea that we use syndrome until we find out the cause, and then we use the word disease. There's something true to that. Or the idea that illness covers a subjective experience and disease the objective condition, or the idea that diseases are progressive and or contagious and or harmful, all parts of the meaning of disease. These subtle differences may be irrelevant or even an unhelpful distraction when considering larger pragmatic issues such as access to care, eligibility for coverage, and allowances for illness. And these latter issues do not depend on the scientific subtleties. So I began to think that any discussion of the scientific subtleties was completely hijacked, and appropriately so, by the larger pragmatic issues of disease status and coverage. Other things to learn from this case: the term disorder is becoming associated with psychiatric conditions, and so much so that those who are keen to have their disorders thought of as physical are resisting the term disorder. People don't want physical conditions confused with psychiatric ones, so that may be because it's an error, but it may also be because psychiatric conditions are taken less seriously and often stigmatized. If the case of psychiatric disorder is similar to the case of migraine, there may be subtle questions having to do with our relative lack of biological understanding of psychiatric disorders, but these may be eclipsed by the pragmatics of inclusion or exclusion in the concept of psychiatric disorder. And that's what I'm going to argue. So I'm going to turn now to the phenomenon of grief, a phenomenon that most argue does not belong in the category of psychiatric disorder, but some argue does. So it's one of those difficult cases. Grief is the human reaction to loss. Losses vary in intensity, depending on their magnitude and also on their meaning to the person who has experienced the loss. The most profound grief is typically experienced for closest friends and family members. And loss of a child, especially traumatic grief, frequently results in profound grief, including psychosis, symptoms of psychosis, and risk of suicide. The symptoms of grief have considerable overlap with the symptoms of depression. So that's just some facts about grief. So question, is grief or severe grief or prolonged grief, some part of grief, a psychiatric disorder? The usual answer is a resounding no, and a statement of the following: grief is a normal reaction to severe loss. And I mentioned some people who say that. A quote is from a recent pre-DSM-5 paper that was wondering what to do with grief, basically said, no one wants to pathologize grief. So disease and disorder status is largely rejected. The typical claim is there's nothing wrong with a severe grief reaction, or a severe grief reaction is the price of love. That this is what it is to be human, and it should not be pathologized. I'm intentionally wanting to look at the range of grief, and in particular have used Jean Cacciatore's work on traumatic loss of a child, where she describes the profundity of grief and the psychiatric symptoms that follow grief, but she is dead set against treating them as psychiatric conditions. She says bitterly, shall I send these people up to a psychiatrist to diagnose them with a disease? And her answer is, no, of course not. They need grief therapy. They don't have a disease. Okay, so I think there's some problems with claiming that grief is not a disorder. One of the big problems is that psychiatric treatment for grief can be helpful. And by treatment, I include the range of physical interventions and talk therapy interventions. There are also biological reasons for resisting the idea that grief is not a disorder. Grief is a disorder. The symptoms of grief are similar to or the same as the symptoms of depression, the overlapping symptoms, and specifically maternal deprivation, which is a model of animal loss, at any rate. It's not a model of human loss, but it's a lab model for depression in animals, as is in general chronic stress, a lab model for depression in animals. So our animal studies of depression are actually animal studies of loss and stress. So that should give us pause. And maybe we would, if we really thought that grief was not a disorder, we should have an animal model of depression, not an animal model of grief. And the third reason has to do with what I think about hostage taking. I think saying that grief is not a disorder makes disorders all the more stigmatizing. When Jean Cacciatore said, you know, shall I send them to a psychiatrist? I found that a kind of stigmatizing statement. Only people who are not normal need to go to a psychiatrist, something like that. So what if the answer, shall I send them to a psychiatrist to diagnose them with a disease, was yes? Here's another way of thinking about grief. And there are not many people with me on this. Grief is a psychiatric disorder. Well, how about the statement, no one wants to pathologize grief? I guess I asked the question, what does it mean to pathologize grief? Again, we've got another word here, pathology. What does pathology mean? What does it mean to pathologize? Are we thinking about 19th century microscope slides here? What exactly is the problem? Again, I'm willing to go there. I'm willing to pathologize grief. people resist the stigma attached to pathologization by saying there's nothing wrong with me. And, you know, people like Jerome Wakefield will say things like it's a conceptual error to classify a normal response as a psychiatric disorder. And I'm suggesting that it's not. Or if it is a conceptual error, we make conceptual errors all the time. I mean, what I would say is our concepts are not that clear. Are not that clear that we can say it's a conceptual error. And I have a suggestion to ease the acceptability of this non-usual answer, and that's to think of grief as a psychological injury, and then include psychological injury in the larger concept of psychological disorder. And I'm doing that in just the same way as it's standard to include physical injury in the larger concept of physical disease. So when you look at the list of physical diseases, they include injuries like broken leg and so on and so forth. So what I'm suggesting is that when we look at the list of psychological disorders, they should include injuries like recent loss. Here are some worries that you may have in mind. The word disorder, not a very good word, because nothing's disordered in most grief. I mean, it's all in order. The person is responding as is normal for humans to respond. So calling grief a psychological disorder is a contradiction in terms. Well, my answer to that is the case for disorder in psychiatric disorders is not established, any of them, not just grief. We don't know that there's disorder in the schizophrenic or depressed brain. In fact, maybe there's more order than there is in the normal brain. We don't know. Disorder has not been meant literally. It is, or it's becoming a technical term. So I'm sympathetic with saying nothing's disordered, but I think the way the term is being used here is not literally. Another rejoinder is, well, maybe we should use the word dysfunction, and that's been very popular with those who like to define physical disease in terms of dysfunction. And I think that's just as problematic. The case for the dysfunction has not been made. The term is often used equivocally. Is it the brain that's dysfunctional? Is it the psyche? Is it the person's activities of daily life, as in when you say that somebody's, quote, not functional? In any case, evolutionary psychiatry, which has some interesting ideas about the nature of psychiatric disorders, insists on the functionality of psychiatric disorders. We haven't established that psychiatric disorders are dysfunctional. So if we want to use the word dysfunction, I think it has to be used as non-literally as the word disorder. It's not actually giving us a substantive characterization of what is disordered or dysfunction. So in conclusion, some recommendations for ameliorative work on the concept of psychiatric disorder. Avoid increasing the stigma of psychiatric disorders by hostage-taking moves. So don't hesitate to put non-stigmatized things into psychiatric disorders, or conversely, to remove psychiatric things, move stigmatized things from psychiatric disorders. So, for example, pedophilia should perhaps be removed from psychiatric disorders because it's a crime, not because it's psychiatrically disordered to sexually desired children. Controversial matter, but just another thing going on in my head. In general, we should aim for concepts that promote justice in healthcare. So those are my recommendations, and I am eager to hear your questions.
Thank you very much. Thank you. We're now gonna have time for questions. So as usual, we're asking you to write in the chat your name or that you have a question, and this way we can follow the order. So we have a first question from Rachel Cooper.
Yeah, thanks. I thought that was all really, really interesting. I wanted to ask you, so just at the end, you were talking about this Ameliorative project, and you commented that we shouldn't hesitate to remove to include non-stigmatizing conditions and remove stigmatizing conditions. And I can see where you're coming from, but I guess, as you noted with the migraine case, there are lots of, and that's not the only case, so it's similar for people with kind of chronic fatigue syndrome, so there's lots of patient groups where people have conditions where, I know, potentially they could be seen as being psychosomatic, or the patient groups feel that they're not maybe taken as seriously as they want to be. And people in those groups tend to be really, really clear that they don't want it to be considered to be a psychiatric disorder. Like, it's really important for them to kind of to emphasize, well, as you were describing, to kind of pick terms that make it seem as physical as possible. And so I guess I was wondering how you thought of the role of the philosopher in kind of resolving those kind of conflicts. Because, so on the one hand, when you're talking about the dangers of hostage taking and about, you know, wanting to promote justice in healthcare, like, I'm very sympathetic, like, that sounds great. But on the other hand, I also have some sympathy for patient groups where, you know, psychiatric conditions are presently stigmatized. And like, I can understand why groups of people with migraine or people with chronic fatigue syndrome might not want to be considered to have psychiatric disorders. So I was wondering what you thought about that. So kind of like, who has the right to say what's kind of fair enough, a group trying to avoid being stigmatized as opposed to hostage taking, and what's the role of the philosopher in those kinds of conflicts?
Lovely. So the case of the people with migraine, which I know best, is a case where there's two reasons for them not wanting to evoke the idea that this is something psychological. One is stigma of the psychological, but the other is because they think it's a wrong account, and migraines have been said to be psychological for so long. So it's the wrong account. And I think that is kind of mixed motivations. And I'm more sympathetic with the second than I am with the first. So if I was going to, if I was going to be the policeman, which I am not, or philosophers were going to be the policeman, I think I would go first for those people who were resisting the label of psychiatric disorder simply for stigma reasons. The case of migraine and the case of chronic fatigue syndrome and so on, it's not just about the stigma, although they do hostage take. They do reinforce the stigma of psychiatric diseases by saying, I do, this is not in my head. I do not have a psychiatric condition. So I do think they hostage take. It's just that that's not the only thing they do. So it's a more complex decision. And I think that arguing that the etiology of their condition is physical is something they want to say and can legitimately say. So I'm not going to say they shouldn't.
Thank you. The next question is from Jay Jackson.
Hi, Miriam.
Hi.
Excellent talk. Thank you. I wanted to push a little on sort of this what you open up at the end with, and push specifically on this sort of the timing of the DSM-5 TR being introduced simply as sort of this or like being introduced where specifically it is for the advent of introducing prolonged grief disorder at the time that we are facing a worldwide pandemic that is that has taken so many people from us and sort of like has also disrupted the very sort of day-to-day life, which in itself has provided for sort of this context of grief for a lot of people, if not all of us. And I wonder whether, or like I am having trouble sort of interpreting how to take this news, or how to take this new concept or this new disorder, because it seems to some extent that it is this sort of ameliorative case because of the way that insurance companies work within the United States, that it seems that this is at least like trying to legitimate treatment or legitimate some sort of like grief is something that can be reimbursed through insurance providers or something like that. But also it seems cynical, right? It seems that it's almost cynical to take this sort of like world historical moment and then add that people who are disruptive or have lived through disruption or like in a prolonged sense of grief for 2 years or more, or like I think that's the cutoff in terms of like the grief or like what allows for it to be prolonged grief rather than regular grief or whatever we want to call it. So I wonder if it's also something where this is importing a lot of or like sort of allowing for this large scale psychiatric creep or diagnostic creep. And so I was wondering if you think that the inclusion in the advent of the pandemic is something that is sort of along the lines of what you're saying in terms of making sure that people have an establishment of care or help, or if it's something that sort of like introduces or reintroduces psychiatric disorder as something that has like a new layer or a new level of stigmatizing or sort of affecting people who have all been disrupted in some way, shape, or form.
Yeah. Well, the DSM-5, the 2013 DSM-5 removed the grief exception. So in DSM-4, you were suffering from depression unless you were 2 months up to 2 months from grief. They removed that so that if you had those symptoms after grief, you would be covered. It was a way of ensuring coverage, if you like. I think you alluded to what they may be doing in terms of revision of putting it back in. It wasn't a popular thing to remove grief, the grief exception, because people thought that it meant that if somebody had a grief reaction, they would be labeled as having depression. And there's a lot of worry about diagnostic creep generally in the DSM, that more and more is going to be counted. You know, we're all suffering from loss, so we're all mentally ill. How could we provide for that? Well, I mean, I really think that we shouldn't decide whether something is a disease or not, depending on whether we think we'll be able to pay for it. That would be just too cynical. And it would mean that we wouldn't have to make the decisions about priorities. We all suffer physical diseases on and off, sometimes continuously. I'm quite comfortable with the idea of saying that many of us are going through grief as a result of the pandemic. I'm also would be quite comfortable with saying many of us are going through depression. If that means that a lot of us could benefit from treatment, I think the answer is yeah. The only thing I wouldn't want to say is that the psychiatrist is the only person who can make you feel better, and the only person who can provide treatment. I think treatment should be defined much more broadly. I don't think disease mongering is a huge concern if what we're talking about is conditions that are harmful and cause suffering.
Thanks.
Thank you. Okay, so it's good. We have a lot of questions. Next one, Catherine Tabb.
Hey, Miriam.
Hi, Katie.
Hey. I'm wondering about, so I think there's something really compelling to me about the idea that people grieving, especially in the extreme cases that you had in mind, certainly need care. But I'm not convinced it's psychiatric care. So it seems to me that at the heart of the objection of people like Wakefield was the overprescription of drugs. So it was a pretty particular concern that when grief was pathologized, it meant that large swaths of the population were being put on antidepressants that then had long-term effects. And for something that might kind of give a nudge, a helpful nudge for the grieving process, but the costs were just too high. So I wonder if this raises another possibility that we might want a category of disorders that are psychological. I really liked your phrase of like psychological injury, but that are not necessarily psychiatric. So we could say that people with extreme grief need care, they need psychotherapy. And in some cases, they might also need drugs, just like anyone else, you know, who goes in for psychotherapy. But that putting the label of psychiatric on just kind of gets us back in the sorts of worries that Wakefield and others have expressed.
Yeah, I am sympathetic to that because I think the word psychiatric is beginning to acquire a drug kind of meaning where it wouldn't have 40 or 50 years ago. But I'm truly not convinced that we know how to separate disorders that benefit from medication from the ones that don't. And you know, what people worry about is a lot with the grief case is the idea that you could take a pill and make the pain go away, and that seems disrespectful to the person who's died and disrespectful to the relationship and all that kind of thing. And I mean, the truth is the pill doesn't do that. So that's not the question we're asking. Sometimes the pill improves symptoms to the point that the person who is suffering can actually process the loss. That seems like a beneficial result to me. So I do agree with the substance of what you said, and that I wish there was a language that was not psychiatry now for psychiatric disorders. I wish it was a broader language, because
I guess that's why I'm wondering about your term psychological injury. It seems like it holds promise as maybe giving us another category. I don't know if you think there would be ways to distinguish between a psychological injury and a psychiatric disease, but if there were, it might open up space for this kind of concern.
Yeah, I'm skeptical about that, actually. I'm truly skeptical about that, even though that's, of course, what Wakefield would want. I think that what goes on when we lose somebody is very similar or the same phenomenon as what goes on when we're depressed. So I'm not interested in separating them. I'm just interested in what's helpful. And I don't mean to suggest by the term psychiatric that it's just drugs that are helpful. In fact, drugs are really crude tools that aren't very good at, anything that we use them for. And talk therapy of various kinds, including group work and exercise therapy and various other kinds of things, all can be very beneficial. All
right, next question from Anne-Marie.
Yeah, thank you for your talk, Miriam. So my question is about it's more a question of clarification about the general framework of the ameliorative approach. So at the beginning of the talk, I think so we should try to make the concept of psychiatric disorder better, but if we fail, then we should try to replace it. And I was just wondering, what do you have in mind when you say that we could fail this project? So in other words, like when do we know that we have failed? And when do we know that we have succeeded in transforming the concept of psychiatric disorder?
Well, I actually hear this question as continuous with Katie's question. And the concept of psychiatric disorder might fail if the concept of psychiatry itself needs to be replaced with something more broadly about mental health. If the concept of psychiatry itself is basically represents a hegemonic takeover by a profession. So if that's what the word psychiatric disorder is doing, if it's saying we psychiatrists are the experts and we say what is to be done, then I'm a little bit worried about it. If we cannot remove stigma, or if it cannot be used in a useful and just way. So I do think it could fail. And I think the most likely reason for failure would be this association with a particular profession, which does not capture everything we want to do about mental health. And the word psychological disorder could be used instead, but that has its own drawbacks. And most people think when you use a thing like psychological disorder, you are not talking about disorders that may have, quote, a biological basis. I mean, all of that is so muddled. But, schizophrenia, for example. Schizophrenia is not thought of as a psychological disorder. Whereas, the more internalizing spectrum disorders of depression and anxiety can be thought of that way. And I don't want to use that distinction either. I think we always have to be careful when we split things, that some parts are going to get stigmatized.
There is a question now from Colin Chamberlain.
Great, thanks, Miriam.
Hi.
Yeah, I want to ask you about the objection that you considered at the end, namely that we shouldn't be classifying grief as a psychiatric disorder, because it's not really a disorder. Like, there's nothing wrong here. Grief is a normal kind of reaction. And one of your responses was, well, we're using disorder in this kind of technical term that needn't have the connotation of like abnormal. And I guess I kind of wondered whether you could like bite the bullet even more by thinking about the analogy to physical injury. Like when I break my leg, like in some sense that's like something normal that happens to human beings. Like we break our legs sometimes in certain conditions, but it's a pretty bad thing for me.
Mm-hmm.
And so you might think when my leg is broken, I'm kind of messed up, I'm kind of disordered. Similarly, then in like the grief case, like when I have lost someone, something bad has happened to me that seems kind of like, I don't know, the emotional equivalent of breaking my leg. Like I have lost someone that I love. And so I wonder if you could say, well, there is something kind of like wrong happening in this situation that the grief is a response to. In the same way that when you suffer a physical injury, there's something like bad happening to your body that your body then like responds to in various ways. So I wonder if there might even be like an even like tighter analogy between the two cases. Might kind of justify the application of disorder.
Sure. And I think one of the things your reflection brings up is that subjective accounts of disease and disorder are very powerful. It's about something bad happening, something, and we're really putting the value term on it, something that's disvalued. And Rachel Cooper stressed that a lot. And I'm certainly willing to say all of that. But what I think I hear you saying as well is that the word disorder is not so bad. You know, when I break my leg, you know, the bones are disordered, they're not in order. And that's true. Although I've never heard anyone actually say they had a disordered bone. And if they said that, it was something else. But if the word disorder works in some way, then great. I just wouldn't want people reading more into it than there is. You know, is a bruise a disorder? Well, it's not that there's cells out of place, it's that, you know, an inflammatory reaction is being triggered and there have been broken blood vessels. So I am not sure that fits so well into the disorder word.
Yeah, I guess I just think when I lose someone that I love, my life is disordered. In a similar kind of way, if I break my leg bones are disordered. Well,
I like that analogy, and we might use it. We might use it to decrease stigma, but I think it's just an analogy. And I'm not sure how far I would push it, because again, my life is disordered. My brain's not disordered. Well, my life's disordered, or my life needs reorganization. Or the order that my life was in no longer works. I don't know what you would do with it. But yeah, I don't mind playing around with those ideas up to a point. I'm always worried about using analogies and what the point they break down. Although I'm recommending one, I'm recommending an analogy with physical injury to loosen people's reluctance to calling grief a disorder.
We're gonna take the next question from Liz. Liz. Okay.
Hello.
Oh, okay.
Sorry, I didn't recognize my own name. I may be disordered. Oh dear. And
we can hear you.
Continue. Okay, sorry. Couple of thoughts came up. First of all, I'm sort of the fox among the chickens, and that I'm not a philosopher. And I'm interested in hearing this because, you know, the ongoing encouragement to go for a holistic mind-body, total person approach to medicine. And, you know, maybe it's just time to marry the two realms of psychiatry and medicine, just as surgery and medicine were married 100 and some years ago. And then we would get away from this whole thing. Now, two comments. One is like one of my first lectures as a medical student, the professor made the comment that disease meant dis-ease, so that which disordered the ease of the individual. And surely, you know, your ease is not just dependent upon the physical self, but also on your mental self. So that's number two. And number three is the DSM as a practicing physician, and I was not a psychiatrist, we always like viewed it with great suspicion because it was in clinical practice. And there's been huge influence by the pharmacological industry. So, many practicing physicians hold it, it's sort of like, yeah, well, it's interesting, but I'm dealing with this person in front of me who, you know, maybe the first issue is a physical one, but almost every physical dis-ease carries with it a burden of mental dis-ease. And I turn it back to you with my three comments. Thank you, and hi, Colin.
Thank you for those comments. And I agree with much of them. I agree with the artificiality of separating psychiatry from the rest of medicine, and especially with the current practice of separating reimbursement for psychiatry from the rest of medicine, which is still going on. And I also agree with your comment that the DSM is looked at with some suspicion by mental health practitioners and people who are bordering on that, but work in other areas of medicine. It is true that some diagnostic categories like childhood bipolar disorder are there because of the push from pharmaceutical companies, and there's very little evidence for them. And I think that's a huge problem. And there are many other problems with the DSM. So I'm not suggesting that everything anyone has ever suggested is a problem for human beings should be in there in the DSM. But I agree with you that psychiatric health is something that it needs attention in all of us, not just those who see psychiatrists. So I'm with you on that. at least.
Thank you. Do you mind, Rachel Cooper, if I give the question to the next person, and because you already asked one, we keep it for later if there is time?
Yeah, that's fine.
Okay, great, thank you. So the next question is from Juliette Ferry-Danini.
Hi,
Hi,
Juliette.
thank you. Hi, Miriam. So actually my question is very similar to Colin's question. I'm wondering about the claim that you attribute to Wakefield, that normal responses cannot be considered as diseases, because it just seems wrong, just like not the case. Pain, fever, for instance, are just normal responses of the body. They are just examples that usually people give. And it seems obvious that we consider them as something that we will treat in medical systems. And so I'm just wondering about that. And I have a second point. So I'm a little bit confused about the whole topic, because I think in French, we don't have the word disorder, and we don't really have anything like grief either. And I think we could translate grief in something like suffering. And I feel like that's what we are talking about. And that's why it's very similar to Colin's point. It's just suffering. And it's the case that both psychological and biological suffering is something that we cater to in medical system, whether or not they are, conceptually disordered. So I feel like the word disordered brings confusion to the topic. So yeah, that's my question. Very biased by my native language. Yeah.
So yeah, it would be interesting to me to dig a little deeper into how the concepts come out in French, because I don't know how they do, and that might be quite enlightening.
I think we would talk about psychological suffering, but I'm not sure.
I presume there's a word for mourning, as in mourning somebody you lost.
Yes and no. But it's not really the emotion. It's just the social aspect. I think. Yeah, I know there is mourning, but I don't feel like nobody would say I'm feeling dirty. Like that's not something. It's not an emotion. It's just a definition of your state as someone who lost someone, but it's not an emotion. So it cannot be disordered. And
Right.
Doesn't even mean you are suffering, actually.
Well, I think just sadness, which is triste, right?
Yeah.
It's
Chagrin.
enough.
Yeah.
Is enough if it's extreme enough. And one of the things that Wakefield argued, and I think he's right on this, is that we seem to privilege bereavement over other kinds of losses in discussions like the DSM discussion of the grief exclusion. But the truth is that there are many kinds of losses, and they can all have profound effects. And if there's an exclusion for grief, perhaps there should be an exclusion for job loss. Or perhaps there should be an exclusion for becoming disabled through an accident, etc. And I agree with Wakefield about that. I think that these are profound injuries.
Yeah, I like that you used the word injury. So thanks for that. Thank you for replying to my question. Thanks.
Thank you. Next question, Phoebe Friesen.
Thank you. And thanks for a really fascinating talk, Miriam. I feel really intrigued by this proposal of, bringing psychological injury and grief with it into the umbrella of psychiatric disorder. I do think there's some real intuitiveness there, and it does seem to be ameliorative and destigmatizing. But then I worry about, at the beginning, you said that there is this constant problem of putting a new term on something stigmatized, and then over time it becomes stigmatized. And I think this maybe relates to Rachel's question, in that we bring in the non-stigmatized to destigmatize, but there seems to be this kind of bi-directional, what was the term, hostage taking, that either side is sort of pushing and pulling. And I think one thing about the notion of injury is it comes with this sort of clear causal story, which in itself is destigmatizing. When there's no causal story in medicine, that's the murky area. That these sort of Scotch conditions, probably many of them are not well explained. And of course, psychiatry is full of the lack of explanations and causal stories. And there's tons of stigma, I think, related to that. This sort of, it's all in your head, we don't know why it's happening. And so I don't know, do you think there would be this inevitability of this battle between the psychological injury and the more murky, difficult to explain conditions under the psychiatric umbrella? And then I guess the question following from that, is this ameliorative project and kind of eternal one? And maybe that's okay, but do you think it's sort of endless?
Well, the question is disability going to stay a useful term, or is it going to be replaced at some point? Is African American going to remain a good term, or is it going to be replaced? And I don't know what the answer is to those questions. I don't know whether terms can kind of, well, certainly terms more often become pejorative than they drift the other direction. So it sounds to me that there needs to be a nudge to help them be viewed more positively. Yeah, my recommendations are not such that if everyone follows this, we'll be fine, because that's not how language works. We can't put language out that way. And philosophers, while I believe they have a role to play, don't have undue influence, don't have huge influence. We would have to see what unfolds over time. And, Rachel Cooper has warned us over and over again that it's hard to know what's going to happen over time. And that ideas that, you may think that looks like a good idea can come back and bite you and so on. And I think that's all true. I think we have to be careful.
Thank you.
Thank you. So we won't have time for all the questions, I'm afraid, but we still have time for one or two, and then I invite the people that wanted to ask a question maybe to write to Miriam Solomon, if that's okay with you. So thank you. Next one is from Bennett Knox.
Hello. Thank you so much for the talk. I'm really broadly sympathetic to most of what you have to say, particularly the grief stuff. I did want to propose, so at sort of the end, you give these sorts of desiderata for doing this ameliorative work. And I was thinking that one you might want to add would be how the sorts of moves the conceptual moves that we do around disorders or whatever, can have effects on other systems of social injustice. So I was thinking about the grief case, and I mean, obviously loss and grief are maldistributed as a result of these other systems of social injustice. And so you might think that one problem with like pathologizing grief might be that, well, we're going to be treating as a medical problem something that's really a social justice issue that needs a political solution. And I mean, that's obviously not confined to just grief. And it seems like something that should just be on our minds when we're making these sorts of conceptual moves in general. So I just wanted to suggest that and see what you think.
Yeah, that's a very interesting suggestion. And I'll think about it. But I'm certainly sympathetic to the suggestion that we need to think more broadly as well.
That gives us time for maybe a last question, if that's okay. So from Max Engleman.
Hi, Miriam. Thanks for that talk. I found it really interesting. I guess really quickly, one thing that I was thinking of was possibly the role that meaning or significance was playing in our understanding of, how to identify something as a disorder or a syndrome or what have you. You mentioned that with grief, well, meaning has a role to play in that, well, we experience grief when we lose something that matters to us, that's meaningful to us. Mm-hmm. And it doesn't seem like meaning would play the same sort of role with a case like migraine or a physical injury. And I was also thinking of things like end of life anxiety, where you're told that you're going to pass away, and that anxiety that's produced in those cases is the product of you thinking about the things that matter to you and the significance of you leaving people behind who matter to you and so on. So I was just thinking, does meaning have a role to play in kind of how we should be distinguishing things like disorders from diseases and so on and so forth? What sort of role do you think it plays?
Well, if I think about migraine and meaning, I would say that certainly the pain part of migraine, which is the part that causes the most suffering, is very sensitive to meaning. Pain is a combination of, biological and psychological and social stuff. And pain is such a common symptom in physical disease. So I certainly wouldn't want to reserve, I wouldn't want to use meaning as a criterion for a psychiatric disorder. We're much more integrated than that. I think considerations of meaning matter for many physical disorders as well.
Thank you very much. I think it's time to thank our speaker, Miriam Solomon. Thank you very much. And so there are comments in the chat. You can save it if you want by clicking on the three dots. And yeah, I invite the discussion to continue, but we have to stop for today here. So we also want to thank you, all of you for attending today, for participating very actively, and for those of you who have been there since the beginning. It's always great to welcome everyone. And we are at our last session of the semester, as Anne-Marie was telling you at the beginning. So please stay tuned, because we're coming back probably at the end of January for a new series. You can go on our website that I'll put in the chat now, and we also have a Facebook. If you want to check what we're doing, please come back in January. We wish you a great December, and hope to see you again very soon. Thank you very much to everyone, and thank you, Miriam Solomon.